rest. We really thankful, and it's an honor and pleasure to have him with us tonight. He will be talking to us about role of target temperature management after cardiac arrest. So please, without any further delay, and welcome with me, Prof. Brenner, and please start your presentation.
Yes, good evening, and sorry again for the technical issue. We lost 20 minutes. I don't know, should I make it shorter or should I give the whole talk?
No, it's okay. Give whole talk.
Okay. Okay.
We'll be happy really to listen to you, Prof.
Okay. Okay.
Thank you very much.
So this is my potential conflict of interest. I receive speakers honoraria from Bard and Sol, but not today, not for this talk. This talk is without any speakers honorarium. So when we speak about target temperature management, actually target temperature management is dead. Why is it dead? Not the concept itself is dead, but the term is dead. In 2009, until 2009, we used therapeutic hypothermia. And in 2009, there was a meeting in Puerto Rico where these societies met, you can see here, and it was decided to use instead the term of therapeutic hypothermia, target temperature management. So since 2009, we are using target temperature management. Until recently, the ILCOR is the parent organization of all the different resuscitation organizations around the world. So the ILCOR gave the recommendation to leave the expression targeted temperature management because it's associated with the two randomized trials you're probably aware of. And the recommendation now is to use instead the term target temperature management, to use the term hypothermic temperature control, normothermic temperature control, fever prevention temperature control, or no temperature control. So these are the new terms we should use. We should not use targeted temperature management anymore. So now let's go a little bit into the history of the development of the guidelines concerning hypothermia or temperature management. As you might remember, already more than 15 years ago, there was the first recommendations by the European Resuscitation Council and by the American Heart Association to use a temperature range between 32 to 34 degrees in patients successfully resuscitated from cardiac arrest. And this recommendation was mainly based on two studies. One of them you can see here, the temperature curve. It's the HACA trial, which was published in New England in 2002. And this study compared hypothermia at 33 degrees with normothermia and showed improved neurologic outcome in patients treated with hypothermia. But the criticism of the study was that the control group actually was not really normothermic, but was slightly hypothermic, as you can see here, almost 38 degrees. So this is the reason why then another group, under the leadership of Niklas Nielsen, they did a randomized trial comparing 33 degrees with strict normothermia. So 36 degrees was the aim. The hypothesis was that it's not the hypothermia which benefits the patients, it was the fever which harmed the patient. And maybe we don't need hypothermia if we keep the patients at the normothermic temperature. So this was the rationale of the study. And what this study showed, to the surprise of everybody, that actually, if you look at the survival, there was no difference in survival between the 33 and the 36 degree group. That's why there are some limitations to this study. One limitation is that randomization was allowed up to 4 hours after restoration of spontaneous circulation. And the cooling was very slow. So actually the target temperature was reached only after 12 hours, which is potentially out of the therapeutic window for this treatment. However, another limitation is that basic life support was provided in 90% of the patient, and no flow time was 0 minutes. So there was a very high proportion of patients who received basic life support, 90%. And therefore, the no flow time was very short, only 0 minutes. So a quite healthy patient population and long time to achieve target temperature. Despite these limitations, this one study led to a change of the guidelines in 2015, recommending a temperature range between 32 and 36 degrees in patients successfully resuscitated from cardiac arrest. And then there was the recent study by Dankiewicz from the same study group. They compared 33 degree with normothermia on the upper limit, so preventing fever, which was defined as less than 37.7 degrees. So you can see here, this is the control group, and this was the treatment group. This study had the same limitations as the study by Nielsen, meaning a very long time to start cooling and a very long time to achieve target temperature, and a very healthy patient population. And this study as well showed no difference in outcome between normothermia and hypothermia. That's why now the latest guidelines from the ILCOR in 2021, they recommend actually to prevent fever. And they also say that there is insufficient evidence to recommend for or against the lower temperature. So these are the latest guidelines, together the ERC and the European Society of Intensive Care. We should monitor core temperature. We should prevent fever for at least 72 hours. We should prevent fever by exposing the patient or use antipyretic drugs or a cooling device. And now they say it's insufficient evidence against or for a lower temperature. And we should not use pre-hospital cooling with cold IV. These are the guidelines. However, I and other experts in the field do not agree with these guidelines. So I agree we should monitor the core temperature. I do not agree with the target temperature. I partially agree with the duration. I do not agree that we should use antipyretic drugs. I do not agree with this sentence here, and I do not agree with this. And I will now go into these two issues and try to give you a rationale why I still think that 33 degrees is the right temperature range for our patients after cardiac arrest. Why do I think that? Well, if you look at pathophysiology, what happens after cardiac arrest and resuscitation, immediately with reperfusion, numerous cascades start leading to cell death by either necrosis or apoptosis. This starts immediately with reperfusion and lasts over hours, days, even over weeks, where the neurons die to all these mechanisms. And there are numerous cell culture studies showing that hypothermia at the range of 32 to 34 degrees is beneficial on many of these cascades. Not only one cascade, but many of these cascades are influenced by hypothermic temperature range between 32 and 34 degrees. If we move on to animal studies, we very recently published a meta-analysis of all cardiac arrest animal studies. So these are models using cardiac arrest. It's not brain ischemia, it's only real whole body ischemia cardiac arrest models, and there are approximately 60 studies. And all the studies, they show in the same direction, that hypothermia is beneficial. And if you look at the summary effect, it's a very, very strong effect of hypothermia. Mortality is reduced by almost 70% in these animal control studies. So hypothermia seems to be a very powerful therapy. And there's only one example of these animal studies. It shows that hypothermia seems to have a U-shaped effect. You can see here was a brain cardiac arrest model where the animals were treated with normothermia, 35 degrees, 33.5, or 30 degrees. And here you see the number of damaged cells. And with normothermia, they are the most damaged cells. And the least damaged cells are with 33.5. If you go deeper, not good. If you go higher, not good. It's a U-shaped effect. And the same is true for caspase. The least caspase release is with 33.5. And look at this difference. It's a huge difference. So there seems to be the sweet spot of 33 degrees. Now let's move on to human studies. What happened after the recommendation changed to 36 degrees and some centers actually changed to 36 degrees? What happened? What you see here, a number of retrospective studies. And the ones among you who are not so familiar with reading a meta-analysis. So this is the single study. The blue point is the effect of hypothermia. And this is the 95% confidence interval of the effect. And if the effect crosses 1, means this is not statistically significant. So this was a trend favoring hypothermia, not statistically significant. In this study, there was no effect, 0. In this study here, this was a statistically significant effect of hypothermia because the 95% confidence interval does not cross 1. And if you look at the summary effect, so if you take all the studies together, you increase power, then the effect of hypothermia was statistically significant. So as an indicator, after switching to 36 degrees, compared to 33 degrees, patients did worse in terms of neurologic outcome. This is a large database from Australia and New Zealand, 16,000 cardiac arrest patients. And you can see here over the years from 2005 to 2013, temperature of these patients slowly decreased. But this was not a big change. You can see here on the y-axis, it's from 34.5 to 34 degrees, slightly below. And then with the new guidelines allowing 36 degrees, most of the centers changed temperature. And you can see that the temperature slowly went up. Again, it's not a big change. Look at the y-axis. It's not even 36 degrees. It's around 35 degrees. So a slow, a very subtle change in temperature. However, if we look at the mortality in this patient population, similar to the temperature decrease, mortality decreased. But then with the change to a higher temperature, which was only slightly higher, this trend of mortality not only stopped, but we could observe increased mortality in these patients. So this is an indication for me that something happened after these centers changed to 36 degrees. And now I want to come to the data which led to the recent guidelines I showed you before. This recommendation is mainly based on these two meta-analyses. And what they did, they looked at randomized clinical trials and differentiated studies looking at outcome at hospital discharge or 30 days, and looked studies which reported outcome at 90 or 180 days. And to make it clearer for you, the same studies, just took out all this in the middle, so it's easier to see. As you can see here, reporting discharge for 30 days, the summary effect, there was a trend favoring hypothermia. However, this trend was not statistically significant. And the same is if you look at studies reporting outcome at 90 or 180 days, this is statistically significant, these are not. And the summary effect, a trend of better outcome for hypothermia, but not statistically significant. If you look more closely, so there are only two studies which reported outcome at 30 days, 90 days, and 180 days. The other studies in red either reported good outcome at 30 days or at 90, 180 days. And this study, they all showed a very clear trend favoring hypothermia. But as I said before, if you reduce the number of studies or the number of participants, you decrease power. The less numbers, the more pronounced the effect has to be statistically significant. And that's what this meta-analysis did. They just separated the studies having low power. So the trend we saw was not statistically significant. And that's not necessary because we know from other studies, and especially from cardiac arrest studies, that the outcome does not change over time. Actually, it's not needed to make two meta-analyses. You could put all the data together in one meta-analysis, increasing the number of studies and increasing the power. And this was done very recently in a Cochrane publication, which is under submission. And in the first analysis, conventional cooling versus no cooling or fever control, you see a statistically significant effect of cooling versus no cooling or fever control. If you look at conventional cooling versus 36 degrees, there was a trend for better outcome for cooling, but not statistically significant because only 3 studies, so that it's not powered enough. And if you take the summary effect of all the studies available, there is a statistically significant effect of hypothermia. And these are the studies, 1, 2, 3, 4, 5, 6 studies, which were not included in the previous meta-analysis leading to the new guidelines. So depending on how you do the meta-analysis, you find a significant effect or you don't find a significant effect. I trust in the Cochrane library because it's the highest level of evidence. And I think that this meta-analysis is the correct one. So there is a statistically significant effect of hypothermia versus 36 or no cooling or fever prevention. Then there is this one sentence in the guidelines saying there's currently insufficient evidence to recommend for or against the temperature at 32 to 36 degrees in subpopulations of cardiac arrest patients. So now I want to go into these subpopulations. Do we really have insufficient evidence? I think we have good evidence, and I will show you the evidence now. This is the first study. It's a guy from Germany, Bernd Böttiger, he looked at different studies which compared hypothermia with normothermia and looked at the rate of bystander CPR. And that's the benefit of hypothermia. You can see the higher the rate of bystander CPR was, the less the effect of hypothermia. And these are the two TTM studies where we had a very high rate of bystander CPR. This is in Europe, another part of Europe, where you don't have a high rise bystander CPR. And if you have a more sicker population, it seems that hypothermia works. If you have very short no-flow time, high rate of bystander CPR, then the effect of hypothermia is not there. Now, if you look at the no-flow time, and this is similar as the other meta-analysis, this is 1 minute no-flow time. And if this line, the 95% confidence interval crosses this line, it's no statistically significant effect. So in a patient population with less than 1 minute no-flow time, there's no effect of hypothermia. With a no-flow time of 1 to 2 minutes, there's no effect of hypothermia. But with a longer duration of no-flow time, 3 to 8 minutes or 9 to 20 minutes, then we can observe a beneficial effect of hypothermia. And if you remember, in the TTM1 study, no-flow time was 1 minute. So we are in this population here where we don't see an effect of hypothermia because the patients are too healthy. This is another very interesting study from the US. What they did, they treated patients from 2010 to 2013 with 33 degrees, and after the change in the guidelines, it was up to the treating physicians if they treat at 33 or 36 degrees. And they did kind of a severity score of patients after cardiac arrest. So 1 is not severely damaged and 4 is severely damaged. And if you look in this patient population, which is not severely damaged, but intermediate damaged, and you look at good outcome, that's the modified ranking score, 0 to 3 means good neurologic outcome. Patients who were treated with 33 degree, 24% had good neurologic outcome versus 6% in the patient population which was treated with 36 degree. Meaning outcome was 3 times better in the patient which was treated with 33 degree as compared to 36 degree. But only in this population here, which was not too severe damaged and which was not damaged enough. This is a study from Japan, which looked at the lactate at arrival, mild, moderate, severe. And if you look now in the patient population, which was cooled and which was not cooled, and that's the favorable neurologic outcome, only in this patient population with a severe lactatemia, in this patient group, hypothermia was beneficial as compared to normothermia. In this moderate damage, there was a trend of better outcome, and in the mildly damaged, there was no difference in hypothermia or normothermia. And if you remember in the TTM 1 and 2 studies, lactate was in a range up to 7. So in the TTM study, we had this patient population. So no wonder that in these 2 studies, hypothermia did not work because patients were not injured enough. This is the same study group, but they developed a better score. Besides lactate having other parameters to have a score for low damage, moderate damage, and high damage. And only in this moderately damaged study population, hypothermia improved statistically significant outcome. In the low damage, no benefit of hypothermia. In the high damage, no benefit of hypothermia. Only in this moderately damaged patient population. This study is from the Netherlands. Very nice study. What they did is they put an EEG on the patients and defined a group with mild encephalopathy, moderate encephalopathy, and severe encephalopathy. And the green ones are the good ones. And in the mild encephalopathy, there was a trend of better outcome with hypothermia. It was not statistically significant. But in this study population with moderate encephalopathy, patients treated with hypothermia were statistically significant better. In the severe encephalopathy, you can do whatever you want. You can give hypothermia, chicken soup, holy water. There's no difference in outcome because the brain is too severely damaged. Nothing will help. And that's just another kind of presentation. You already know this now. It's like a meta-analysis. Only in the moderate encephalopathy, the effect of hypothermia was statistically significant. I have one more. A network meta-analysis of 42 studies looking at the time of collapse to restoration of spontaneous circulation. And that's good neurologic outcome. And only in the group with a time from collapse to ROSC between 20 and 39 minutes, or 20 to 40 minutes, the effect of hypothermia was statistically significant. In a short duration, there was almost no effect. In a longer duration, there was a trend, not statistically significant, as well as here. So in the short time, no effect, longer time, effect of hypothermia. So it seems that there needs to be a little bit of damage of the brain that hypothermia can exert its beneficial effect. And now if you look how many patients are in these subgroups. So this is the total number of the study, and that's the study population which is medium damaged, which benefited from hypothermia, and these are 40%. So 40% actually, they benefit from hypothermia. That's the patient population which is damaged enough, but not damaged too severely. So this means hypothermia is not for all the patients. It's for a certain subpopulation, but a big subpopulation. 40% of the patients in these studies, they benefited from hypothermia. So that's why I believe, and I hope you kind of could follow me with my evidence, what I showed you, based on this evidence that 33 degrees is the temperature we should target. Now let's come to this point, preventing fever for at least 72 hours. Well, I'm against preventing fever, but I'm for 72 hours. Why I'm for 72 hours? Up to recently, hypothermia was applied for 24 hours. This was always the recommendation, but we know that the damage to the brain continues longer than 24 hours, goes even over weeks. Once we stop cooling at 24 hours, if the damage continues longer than 24 hours. And there was one human study looked at 48 hours cooling comparing to 24 hours of cooling. And what that study showed was that there was a trend of reduced mortality in the 48 hours group. However, this was not statistically significant. But if you look in the same study to cognitive impairment, you can see that the non-impaired, statistically significant, more patients had good cognitive outcome when cooling was prolonged for 48 hours as compared to 24 hours. And the ones among you who treat neonates after brain encephalopathy, after birth, we cool them for 72 hours, no discussion. Why do we stop in adults after 24 hours? So I would recommend also in adult patients to increase the duration of hypothermia as we do in neonates. Now comes the last point I want to discuss is the recommendation. It's a strong recommendation, not using pre-hospital cooling with cold IV. Well, if you look at pathophysiology, the earlier you start cooling, the better it is. I mean, that's common sense. And if you look at animal studies, they all show the same consistently. The earlier you start, the better it is. If you look at one of our retrospective studies, where patients were cooled out of the hospital and in the hospital continued, it took 19 minutes to start cooling, very, very fast. And when a patient group with in-hospital cooling, it took almost 1.5 hours to start cooling or no cooling. And if you cool only in the hospital, the odds for survival decreases by 33% as compared to out and in-hospital cooling. And if you do not do any cooling, then you decrease the odds for survival by almost 50%. So that's for me a very clear indication that we should start already out of the hospital. But this was only a retrospective study. Another retrospective study looked at the time to start cooling. So not time to reach target temperature, but time to start cooling. And with every 30 minutes delay, the odds for poor outcome increased by 10%. So every 30 minutes later, 10% more poor outcome. But this was also a retrospective study. And as you know, the guidelines, they always want to have prospective randomized trials. It's the gold standard. And there are 1, 2, 3, 4 randomized clinical trials. And if you look here at the effect, none of the study could show an effect, and also the summary effect. There was no effect in this meta-analysis by Granfeld. However, each of these studies had severe limitations. For example, in the study of Kim, only 30% of the patients which were cooled out of the hospital were cooled in the hospital. So in many patients, cooling was not continued in the hospital. Or in the Australian study, patients who were cooled out of the hospital, when they arrived in the hospital, the temperature increased again. And after some time, the temperature was the same as the patients who were not cooled out of the hospital. And none of the patients achieved a temperature of 33 degrees. So there are severe limitations in these studies. And that's the problem of this meta-analysis, is garbage in, garbage out. If you include patients with severe limitations, you can't expect to find a summary effect because each study itself has severe limitations. And I come back to the Cochrane meta-analysis, which was also done for pre-hospital cooling. And the conclusion of this review was that we cannot include any study in a meta-analysis because these studies were so poor. So you have to be very careful in reading the literature. And the guidelines say we shouldn't use cold fluid because of pulmonary edema. And this was based on one study by Kim. This study showed that in the first X-ray, a higher proportion of patients who were cooled pre-hospital had pulmonary edema. This was statistically significant. However, in a second X-ray, there was no difference in pulmonary edema. So they only looked at the X-ray. And based on this one study, the recommendation is we should not use cold fluid. I think this is a very weak evidence. And there are even other studies from the States. In this study, it was shown that the patients who received pre-hospital cooling actually had less pulmonary edema, statistically significant less pulmonary edema. So this study showed the opposite. So what are we doing with this contradicting literature? I don't understand that based on this very, very weak evidence, the guidelines say we should not use cold fluid. In Vienna, we use in all our patients cold fluid for induction of hypothermia. So I think based on common sense, based on animal studies, we should, and based on retrospective studies, we should start cooling very early and cool as fast as possible. And then the recommendation, we should use antipyretic drugs or expose the patients. Well, I don't think that this is a good method. If you look at the recommendation saying temperature control can be achieved by exposing the patient, that's not true. If you look at the latest study by Tankiewicz using fever prevention, almost 50% of these patients had to be cooled with a cooling device. And look at the standard deviation, how heterogeneous the temperatures are. And it goes even over 38 degrees. So some of these patients had fever. So I think only exposing the patient doesn't work. And in at least 50%, you have to use a cooling device anyhow. And which device we should use? Well, there are different devices. There is endovascular cooling, there's surface cooling, there's cooling with cold fluid. If you use cold fluid, you have to be aware that you have to use a pressure bag, so the cold fluid has to go in very rapidly, and the effect is very short. It's only 1 hour. After 1 hour, the patients warm up. So if you use cold fluid, you have to combine it with a second cooling method that the patient, after the initial cooling with cold fluid, do not warm up again. So you have to use a second cooling device. You should start with the second cooling device with the start of IV cooling. And then the guidelines say concerning the methods, 3 trials compared endovascular cooling and surface cooling and found no difference in survival or neurologic outcome. Well, yes, this is true, but you have to look into more detail into the study. Because what one study showed is if you look at devices with temperature feedback and without temperature feedback, there was a clear beneficial effect if patients were cooled with a device with a temperature feedback. Because without temperature feedback, the temperature goes up and down, up and down, up and down, very poor temperature control. And this seems to be bad for the brain. So you should use a cooling device with temperature feedback to keep the temperature in one level. Now you have endovascular cooling devices with temperature feedback, and you have surface cooling with feedback. And the question is, what is better? Endovascular with feedback or surface cooling with feedback? We know from previous studies that no feedback is bad, but we don't know if there's a difference between these two. So we looked into this in a meta-analysis and looked if we can find a difference not only between endovascular surface, but between endovascular with feedback and surface with feedback. That was the main question. And what we showed is that intravascular cooling is better than, not statistically significant, but a trend of better outcome compared to surface cooling with feedback. There was a clear benefit of endovascular cooling as compared to surface cooling without feedback. And surface cooling with feedback was better than surface cooling without feedback, but only 2 studies. So it was not powered enough that this difference is statistically significant. And if you put all them together, it looks like that the most benefit you get with intravascular cooling had the highest chance of good outcome, followed by surface cooling with feedback, and the lowest chance, or the poorest method, is surface cooling without feedback. So coming to the conclusion now. If you look at cell culture studies showing the effect of hypothermia, looking at animal studies showing a very strong effect of hypothermia, looking at retrospective studies, what happened after the guidelines changed from 33 to 36 degree and mortality of patients, huge database, increased again. If you look at the meta-analysis, this one which led to the guidelines, but separating the studies and having not enough power, that the effect which is shown was not statistically significant. And if you do it correctly, not separating the studies, increase the power of the study, then the summary effect of hypothermia is statistically significant. If you look at the subpopulations I showed you, 40% of the patients are in this range who benefit from hypothermia. And there's no single study showing that hypothermia harms in terms of neurological outcome. There are 2 studies showing no benefit, but the summary effect, there's a benefit. There's no study showing that hypothermia harms. We have a huge subgroup of patients who benefit from hypothermia. And as long as we cannot identify these patients by a marker or whatever, we don't have this, I would cool all the patients to give this patient population the chance to benefit. So that's why, based on the literature I showed you now, it's a vast evidence, I think. My take-home message would be use 33 degree. Do it as early as possible, as fast as possible, and you should use a device with a feedback. Don't do it without feedback. The temperature goes up and down. Thank you very much for your attention, and I'm looking forward to the discussion. Maybe we have 1 or 2 minutes for that.
Thank you very much, Prof. Prenner, for this great summary of the evidence. It's a really wonderful presentation. So we can open the floor for discussion. So if you have questions, please raise your hand and open your mic.
There's one question by Ibrahim Ami.
So Ibrahim, please.
Can he unmute, or you have to do it?
Sure, probably I will.
Thank you, Professor, for the amazing lecture. My question is regarding, you mentioned that there is no side effect regarding the hypothermia about the neurological outcome. But what about the other adverse effect, non-neurological outcome, for those population who will not benefit from the hypothermia?
Yeah. Well, if you look at the literature, there are some studies showing that the rate of pneumonia is higher. Then some studies showed that there's more bradycardia. However, we know that bradycardia sometimes is good for the heart. There are studies showing that potassium and electrolytes are imbalanced. so you have to give potassium. But these are only minor side effects. If you look at neurologic outcome is better. So I accept a higher rate of pneumonia as long as the neurologic outcome is better. And there's no study showing that hypothermia harms the brain. So these side effects are there. But if you look at the brain benefits.
Thank you.
So next will be Ali. So please ask your question.
Can they mute themselves, or you have to do it?
Yes, dear professor, this is Pierre speaking from Switzerland. I'm just wondering, I'm just a neighbor of Austria.
Yes.
Just wondering what the preferred sedation technique you will use for these patients.
That's a very good question. And there's a lot of discussion. What is the best sedation, and should we paralyze the patients? Well, in Vienna, we use sedation and paralyze the patients. So we use propofol for sedation and pancuronium for muscular relaxation. So we paralyze the patients for the duration of hypothermia. It's easier because you can cool faster and you avoid shivering. And we know shivering increases the oxygen demand, and that's not good for the injured brain. That's why we paralyze constantly. There are other groups saying we do not paralyze and wait until the patient starts to shiver, then we give paralytics. However, I think you miss the micro shivering if you do that. So that's why we decided to use sedation and muscle relaxing for the entire period for 24 hours.
Great,
Did this
thank
answer
you.
your question?
Yes, thank you very much, Ashraf. Please, Rose, unmute Ashraf.
Hello.
Yeah.
Hi, Dr. Beringer. I'm Ashraf Gad, one of the neonatologists from Qatar. Thank you for the excellent presentation. My question is how much data we can extrapolate from adults into neonates in the intensive care unit. And my question is specifically is regarding the targeted range of therapeutic hypothermia, because we have subpopulations of patients, neonates who are preterm, when we really encounter, although it's rare, but we encounter some of them below 34 weeks, and we could not use the targeted range of 33.5. Myself, actually, I was thinking one day maybe you can design a study that target temperature that's higher, because based on data that we know as neonatologists that significant hypothermia can affect the mortality of these patients. So most of neonatologists are shy away from using lower temperature. And we don't know what to do with these babies. They later present with brain injury, and we cannot use such a significant hypothermia at 33.5. So what's your advice or your take on this issue?
Well, I'm treating only adults, so I'm not experienced in neonates. I follow the literature, and as far as I remember the literature, in neonates, the evidence is far better to use 33 degrees than in adults. And as far as I know, the guidelines are still to use 33 degrees in neonates who have perinatal brain ischemia, as far as I know, and they use it for 72 hours, isn't it? Isn't that the guideline, the current guideline for neonates?
We are not sure because most of us are adult intensivists.
Yeah. But I think the guidelines in neonates still recommend 33 degrees for 72 hours. And the evidence is quite good. Because what I think why it works in neonates is because they cool very fast. Because the neonates are so small, it's very easy to cool them. And so hypothermia is very fast and very effective. I think that's one of the reasons why in neonates hypothermia works so well. And in adults, it's difficult to show because it takes so long to cool the patients.
Great. So next will be Wala. Please go ahead, Wala.
Yeah. In summary, what is the criteria to use the hypothermia post-cardiac arrest? And the second one is, from your experience, what was the best outcome you reached from implementing hypothermia post-cardiac arrest? Thank you.
The second question was the rate of good outcome. Well, in our study, in the HACA study, we improved outcome from 55% to 35%. So 35% good outcome versus 55% good outcome in hypothermia. This was our benefit, which we showed in the HACA study. And the other question, I didn't get it. Can you ask again? I don't get it. I think the connection is not good now, or is it just the one, or is it me?
I think
maybe upper here only.
Okay.
So maybe we can take the Iman, please.
Hello, Prof.
Hi.
Yes, thanks for this great lecture. I missed a part of it. I would you, if you can just tell us about the rewarming protocol you are following.
Yeah, that's also a very good question, because actually we don't know a lot about the rewarming. It's only based on eminence, not on evidence. From animal studies, it looks like that rewarming should be slow, and we use 0.25 degrees per hour for rewarming, but this is based on nothing. There's no literature for that. It's only it should be slow, we think, but that's only animal studies. It's very, very poor evidence. But our protocol is, to be precise, 0.25 degrees per hour rewarming rate.
Okay, thank you.
Then we have Saleh Shehri. Prof, do you have still more time with us, or?
Yeah, I have time.
Thank you very much. We really appreciate it. So I miss maybe Saleh Shehri. I don't see him anymore. So we have Shahla. Shahla, please go ahead.
Good evening. Good evening, Prof.
Good evening.
Thank you for the nice presentation. It is really informative. My question is only that contraindication, or when we are not going to use, if there is any updates, because last time it was like if patients are severely acidotic or bleeding, we are not going to use hypothermia protocol. And then it end up very less patient on this therapy. So what are the, if there is any update or protocol new?
Well,
thank you.
Yeah, if you decide to use hypothermia, I think there are only few contraindications. Like one contraindication, as you mentioned, would be severe bleeding. However, not many patients after cardiac arrest show severe bleeding. You know, we're not in trauma here. We are in sudden cardiac death, and we hardly have patients who show severe bleeding. Now, maybe they have a little bit of bleeding in the where you put the catheter in, but that's minor. But severe bleeding we hardly have. So actually, we use hypothermia in all patients, except we say there's no intensive care. If we say we withdraw from life support, we don't do hypothermia. If we say we provide intensive care, then hypothermia is part of intensive care, independent of the patient, except severe bleeding. But there are no other, for us, there are no other contraindications. There's cardiogenic shock, we do not exclude, we include, and or severe acetemic, we cool the patients. There's otherwise there's no for us there's no contraindication.
It's just a comment, Prof, like a patient with moderate to severe traumatic brain injury, would you still include?
That's a totally different topic. And
I mean post-cardiac arrest. Post-cardiac arrest, if they have multiple trauma, mainly traumatic brain injury.
Yeah, no, so traumatic brain injury and cardiac arrest. That's also, I think, at least in our hospital, not very often that you have cardiac arrest and brain trauma. If you have brain trauma, only brain trauma, then the literature is very, very contradictory. So there's no clear sign of hypothermia. But if you have TBI and cardiac arrest, I would use hypothermia because of the cardiac arrest. Since hypothermia itself does not harm, so I would use it for the cardiac arrest part of the patient. But it's very rare. I don't know. Do you have a lot of patients who have cardiac arrest and traumatic brain injury?
Not really.
Not really, right? That's very, very rare.
So we have a couple of questions. Maybe we'll take more questions and this until you say stop, Prof.
Okay.
So we have again, thank you very much for your patience. We really appreciate it. So Shahri, again, you're back. So please unmute yourself and ask your question.
Thank you, Prof, for your nice talk. I enjoyed it. Dr. Salah, I'm pediatric intensivist. The principle of hypothermia that you're talking about is very interesting. You know, in the NICU, the people have been introducing that earlier, and then they were back off. Then they realized that later on it's beneficial, reintroduce, and now it's standard.
Now you muted yourself. We don't hear you anymore.
TBI protocol. My question is...
I lost you for some seconds. Yeah, what is your question? Okay, continue.
My question is, what do you think about the quality of, the survival? We are talking about the mortality. Is it a good survival out of the hypothermia groups? Thank you.
Yeah, that's a good question. Most of the studies I showed you looked at neurologic outcome. And I think that's the most important outcome parameter is good neurologic outcome. And most studies, they don't show a benefit in survival. However, they show a benefit in good neurologic outcome. So I think hypothermia has the effect mainly on neurologic outcome, not on mortality. Did this answer your question?
Yes, thank you very much, Prof. Wala?
Thank you, doctors. I would like to clarify my question again regarding the first one. was about the choosing criteria for the patients who I should implement the hypothermia and I would expect the benefit. The other one is how you define the improvement and the patient that you implemented hypothermia from your daily practice. Can you define the improvement for us?
You mean, well, that's difficult to say because after we did the study and after the guidelines, we only used hypothermia. So we do not, so there are no patients we don't cool. So I cannot say that there's a difference because all our patients are cooled now. So compared to historic controls, outcome is better, but we don't have concurrent control because we cool all patients after cardiac arrest. So I cannot tell you if there's a difference if we did not cool now because we cool all the patients. Does this make sense?
Okay.
Hello?
So we'll take last question by Shinara.
Yeah. Good evening, Professor. Thank you very much for your presentation. And my question, maybe it is an unusual question. So what do you think about the patients who got cardiac arrest in the cold weather, for example, with minus? And shall we use the protocol for such patients when the patient will be admitted in the hospital?
I'm not sure if I understood the question. Haifa, did you understand the question?
Yeah, if patient already post-cardiac arrest came to us hypothermic, shall we rewarm him or continue?
Oh, you mean how deep of hypothermia? Well, I would try to aim 33 degrees. So if the patient has 30 degree, I would slowly aim for 33 degree. As you remember, I showed you this one animal studies showing the U-shaped effect of hypothermia with the most benefit in the 33 degrees group. And as you all know from intensive care, 33 degree can make problems. So I would always try to target 33 degrees. So if the patient comes colder, slowly rewarm, best with a temperature, with a device with temperature feedback. You just put in 33 degree and the device itself regulates the temperature up to 33 degrees. So I would warm them with the device to the target of 33 degrees.
If you allow me, Prof, this will be last question.
Yeah.
Most of centers, because of availability, not using or monitoring core temperature. Can we do it with auxiliary temperature?
No. That's very unreliable. And if you use a temperature feedback system, they are calibrated to either Foley temperature, bladder temperature, or we use esophageal temperature. That's what we use. We use esophageal temperature. Auxiliary temperature, that's very unreliable. And you know, if this slips, and if you use a device, you need continuous temperature feedback. And that would be, you know, if you want to take home something with you, one is use a device with temperature feedback, because there are so many retrospective studies showing that this variation in temperature during cooling, that's not good. Yeah, you need a stable temperature at 33 degrees. And you only can achieve this with feedback, and the feedback devices are calibrated to either bladder temperature or esophageal temperature. So axillary or rectal temperature is so poor. You know, if you put the probe into the rectum, you put it in shit, it doesn't react. You know, you cool and cool and cool, and the patient shows 33 degrees, but in reality, you're at 30 degrees because you're measuring the temperature in a big shit. Sorry to say.
Sure. Okay. Thank you very much, Prof. We're really very thankful for joining us and accepting our invitation tonight. Was a great session and great discussion. Thank you very much. And on behalf of the Saudi Critical Care and Neurocritical Care Chapter, we thank you very much for joining us tonight, and hope, inshallah, in the future we'll have another session. Really
it was
appreciate.
my pleasure.
Thank you. Have a good night.
Thank you. Thank you.
Thank you very
Bye.
much for all attendees who join us to this late time. We really appreciate, and goodbye.